So could you tell me if you can see my screen, please?
Yes, we can.
Hello? No, pues.
Yes, we can.
So guys, could you tell me if you can see my screen right now? Hello?
Yes, we can.
Okay, I think we're good now, right? So let's get started. Okay, so today we're actually going to talk about physical examination, okay? So yesterday we actually talked about uh, the first part of medical history, which is about questioning our patient and getting information from our patient or the family members of our patient, right? So that is a more subjective point of view, right? And can anybody tell me what subjective means to you? Bernardo, are you here?
Yes.
Okay, what could you tell me about the meaning you might have about subjective?
Mm, I don't know.
Okay, what about Brisa, maybe?
Subjective is subjetivo in Spanish, right?
Yes.
What I think is something influenced by a personal feeling.
Okay, it could be. Yes, it's like something that you cannot actually determine on your own eyes, right? It is something, for example, pain is something subjective, right? Because you cannot prove it. It is, well, you have to, in some way, you have to trust your patient when your patient tells you that is feeling or is under pain, right? So that is something subjective. So the first part of the medical history is actually really, really subjective. We actually have to believe our patient because we're just asking questions. We ask questions about well, personal information, for example, date of birth and that kind of stuff. And we get all the way through the medical history. We're only asking our patient some questions. So in some way, as I told you, we have to trust our patient. We have to um yes, we have to trust what our patient is mm, telling us, right? We consider that as truth. However, this second part of the medical history is actually is really objective. We determine it by making sure, right, through the physical examination, we make sure about the findings we get through it, right? So the first part that we already talked about is subjective, and the second part is really objective. This is what we get through physical examination. So what are the main objectives of physical examination? You can see them on your screen. The first one would be to describe the components and special considerations involved in taking a subjective history and the objective assessment. As I was telling you, right? You have to match the information that you just got from the first part part of the medical history and match it to the second part, which is the physical examination. There are three main examples of basic movement analysis done at physical examination, and it is to consider to demonstrate how to screen for sensory and strength deficits. We also have to show how to assess reflexes and interpret findings. Interpret ROM and PROM, that's what we're going to talk about later. We're going to find out the meaning of each expression and the findings from a physical examination. So the purpose of physical examination, the screening, looking for indications of pathology. As I told you in the first part, the history and subjective evaluation is what we already talked about. And the second part, we get an objective assessment. Assessment in Spanish would be something like analysis. Okay, so the second part would be un análisis objetivo, right? To match it to the first part, which is subjective actually. So what are we going to focus on? Actually, there are a lot of things to focus on depending on what kind of information you just got at the first part. For example, let's say that a patient goes to your consultation and is well the chief concern, which is actually the motivo de consulta, right? Chief concern. Let's say the chief concern of this determined patient would be, for example, a respiratory problem, right? So the chief concern would be something like cough, shortness of breath, right? And on the objective part, we have to direct our physical examination to that part or to that system of your patient's failure. In this case, would be directed into the respiratory system, right? So in this case, we're basically going to talk a little bit about neurology, okay? So in this presentation, we're focusing on different specialty that we didn't really talk about that much through our classes, which is neurology. So in this case, for example, we would have to take into account the pain, and you already know how to describe the pain, right? The skin integrity, extremity girth, general level of function, sensation, joint run. We're going to talk about that later. Vital signs, strength, special tests, some red flags, reflexes, and gait. Okay. So first of all, we have, as I was telling you, we're going to consider this second part about objective examination. And we're going to, well, we have some things to consider. The first one is to use screening methods consistent to meet the needs, feelings, and responses of the patient. And to keep the patient informed on your intentions, you always have to, well, you give commands to your patients, right? Do this, please do that, turn around, cough, right? And you always have to keep your patient informed why you're doing this, why you're asking your patient to do something, and to perform painful movements at last. When possible, test an involved site first. For example, when we have to check on a patient's abdomen, right? We touch our patient in the last step. because we have to, well, in Spanish would be inspección, right? Auscultación, palpación y percusión in that specific order, right? Because if you get actually, if you start with the last one, you're going to make your patient uncomfortable for the rest of the physical examination. And for example, if your patient has some abdominal pain and you push your patient's abdomen, right? Mm, as a reflex, is going to make his or her muscles, her abdominal muscles, contract. So it will be later, it will be much more difficult to check your patient. So you have to perform some painful movements at the last time. And when it is possible, test uninvolved site first. Let's say we have our patient with, let's say, a fracture, right? On his, I don't know, left leg. And we always have to compare both sides to determine if there is any abnormality. So we have to check the leg that was not involved in the fracture, and right after we have to check our patient's leg, which is involved in a fracture. So first the uninvolved side, and right after the involved side. And what about movement analysis? This is actually a functional assessment, analysis funcional, right? Gait actually means something like step, right? Okay, so we have to observe walkings starting in waiting room. So as you can see here, your physical examination is going to start even before the patient gets to your consultation. Sometimes even actually when, I don't know, we're walking around, walking down the street, we can see a patient walking in a different way, right? And even just looking at this patient, we could get a diagnose, right? Just checking on his or her walking. What do we have to focus on? Antalgic. You do know what antalgic is, right? Okay, let's see. Um, we have, well, Breezy just answered. What about Danitza? Hello, Danitza, are you here?
Antalgic would be antiálgico.
Okay, and how would you explain that in English?
Okay, do to avoid the pain.
Okay, yeah, okay, great. Something a patient does to avoid pain. Okay, deviation. Deviation is like, for example, when a patient has a weak part of his or her body, it actually deviates into the stronger side, right? And to assistive devices, for example, a cripple, right? Posture. different positions, for example, standing, sitting, supine, and different views, anteroposterior and lateral. What about does anybody know any different ways a person could stand and indicate any kind of disease or any action that this person does that indicates any kind of disease when standing? Or laying down or sitting. Come on, it's easy. Okay, what about Marcela? Hello? Okay, guess she's not here. So we're going on. You're going to check on it, okay, later. So we're still going with movement analysis. A protective movement pattern is actually easily observed and should be documented as should inconsistencies. Can anybody give me an example of this? For example, when someone has appendicitis, there's actually, at first, the patient's abdomen muscles are really contracted, are really straightened, okay? However, at the beginning of the disease, it's a voluntary contraction of the muscles. And right after, it is actually involuntary. Okay. Are there any movement patterns consistent with the patient's pain or mobility complaints? We have to consider challenging the movement with more repetitions or way to elicit abnormal movements. And if you, as doctors, are correct, the movement fault, does the pain improve? So we're going on to the vital signs part. We already talked about it, right? Actually, it is a little can anybody tell me the difference between pulse and heart rate, and why is it important to differentiate one from another? Okay, let's get started with what are the five vital signs? They're actually heart rate, right? Frecuencia cardíaca, blood pressure, that is BP, respiratory rate would be frecuencia respiratoria, temperature, temperatura, and this last one is actually now considered a vital sign, which is the peripheral blood oxygen blood saturation, right? Saturación periférica de oxígeno. So as I was saying, why is it important to differentiate pulse from heart rate? Can anybody tell me why is that important? And how are they different? Okay, Danitza Zambrana just joined us. Okay, Brisa, I think you were about to tell us.
Well, I think the pulse is the number of times that the arteries just get expanded,
Okay,
and the heart rate is the number of times that our heart is beating in a minute.
okay. So why is it important to differentiate one from another?
I don't know.
Okay, why is it important when your superior asks you to check on your patient's heart rate? Why do you go and check your patient's pulse?
Because the pulse evaluate how the arteries are going.
Okay, and when your superior asks you to check on your patient's heart rate, why not go on your stethoscope and check the patient's heartbeat? We always go to the pulse, right? And it is actually not that correct. We have to check on our patient's heartbeat through our stethoscope. That is actually how we get heart rate, because pulse is different. You know, you could even tell me in Spanish. In Spanish, well, in English would be the increased heart rate would be tachycardia, right? And the lower heart rate would be bradycardia, right? What about pulse? Can anybody tell me? Hello. Okay, I'm gonna have to ask one by one. Okay, thank you, Brisa. You did good. Okay, what about let's say Paola, maybe? Okay, Mariana, maybe?
Could you please repeat the question?
Yeah, sure. Do you know, well, in English would be, well, maybe, let's say in Spanish, okay, let's say it in Spanish. El incremento de la frecuencia cardíaca es taquicardia, ¿no es cierto? La disminución es bradicardia. Y el incremento por encima de los valores normales del pulso, ¿saben cómo se llama? Y la disminución por debajo de los valores normales.
I really don't know the name.
Okay. In Spanish would be taquisfigmia, okay, y bradysfigmia. Okay, so it is actually important to differentiate pulse from heart rate. Okay, for example, can anybody tell me what Takayasu's disease is all about? Or Takayasu's arteritis, la arteritis de Takayasu? 5 extra points for the one who answers this question. This is kind of tricky.
It's a type of arthritis, I think.
Okay, what diameter of vessels does it get? Well, does it involve?
It is with vasculitis.
Okay, actually, vasculitis tend to involve 3 main types of diameter of vessels. There are large vessel vasculitis, medium vessels vasculitis, and small vessels vasculitis. And in Takayasu's disease, what diameter of vessels does this disease affect? Do you know? And why am I relating it to pulse and heart rate?
I don't know what diameter, but I think it's more than the arterial pressure is more than 10 than the normal, maybe.
Okay. Okay. Let's check on it. Okay. Actually, this Takayasu disease or Takayasu arteritis is a large and medium size vessels vasculitis. Okay, so it actually affects big vessels and medium sized vessels, such as the aorta, right? And some branches, some main branches. For example, clavicular artery. And you know the clavicular artery turns into brachial artery, right? As it goes right into the arm. So since this disease causes the inflammation of these vessels, this disease is actually known as I'm going to say it in Spanish, la enfermedad sin pulso. Okay, and why is this disease known for that name? It's because this artery gets inflamed, right? And if you go to your patient's um, radial pulse, you're not going to find any pulse because there's little blood that is getting to the distal areas of the arm, the forearm actually, right? And it is because the artery is inflamed right in its beginning, in the aorta or in the clavicular artery. So you check on your patient's pulse, you're not going to find it. That is why this is called la enfermedad sin pulso. Okay. And if you go to check on your patient's heart rate through your stethoscope, you are going to find heartbeats. I mean, it is normal, right? However, you're not going to find any pulse. This disease actually affects Asian people. It is much more common in Asian people, actually, in women that are mid-aged women. Okay, so that is actually Takayasu's disease or Takayasu's arteritis, also known as la enfermedad sin pulso. Okay, that is why it is different and it is important to differentiate. It is just one example. There are some other examples in which you can differentiate them. In heart failure, for example, that I already told you about. Okay, let's go on. We also have to be aware of normal ranges. Okay, so heart rate would be, the normal ranges would be from 60 to 100, right? Blood pressure, there's actually undefined values right now because last year we got a last consensus, which tells us that there are more categories. For example, now we call the ideal blood pressure under 180, right? There's actually a new category which tells us about normal and three main types of hypertension according to the values we found. So it depends on what kind of guide you're following. Respiratory rate. So can anybody tell me the normal ranges of respiratory rate? Okay, Danitza Zambrana, you just joined us and I was about to ask you.
In adults, it is 12 or 20 respirations per minute.
Okay, it would be per minute. Okay, PER, per minute. Okay, okay, that would be right. Temperature is easy. Peripheral blood saturation here in La Paz, we actually consider it normal when a patient has values above 90. Actually, what about sea level countries such as El Salvador? Guys from El Salvador here. Paula didn't answer yet. So are you here? Hello, Paola. Who else is from El Salvador here in our meeting? I think, Brisa, are you from El Salvador?
No, I'm not.
Okay. Danitza Zambrana.
No, I'm not.
Okay, who's from El Salvador, guys? We had a lot of guys from El Salvador. I think the only one left is, oh, Marcela, you're from El Salvador?
Yes, I am. I think I'm not pretty sure, but it's between 95 and 99.
Okay, so that would be, thank you. That would be in countries at sea level, right? So we always have to take into account the normal ranges of those vital signs. Here we're going to have a little example on a few systems that we have actually to check on. For example, here we have skin. So what do we have to focus on? The color, if there's edema, right? If it is actually an acute or chronic edema. Can anybody give me an example of lymph swelling or edema? Okay, easier one. Acute edema. Can anybody give me an example of acute edema? In what kind of disease can we find acute edema? Hello. Okay, acute edema, for example, in heart failure, right? In kidney failure and chronic edema. Anybody? Well, what about the obstruction of, for example, when a patient has prostate cancer, sometimes could develop lymph edema. Okay. And we have to also to focus on the texture of the skin and some abnormalities such as fragility, ecchymosis, warmth and redness, shiny appearance. Okay, what about sensation? Assess is in Spanish would be analizar. Okay, so we have to assess to determine the extent and cause of sensory loss, to determine the degree and the level of impairment, and to make prognostic evaluation of injury. And sensory rationality, we will have to differentiate the source of nerve injury. For example, in nerve root would be raíz, right? Nerve root injury, we're going to have to consider on what dermatome the lesion is. And the is the sensory distribution of skin supplied by a single nerve root. Injury that manifests in a dermatomal pattern. So, you all know about dermatomes, right? Let's see. What about Mariana? You must have read about dermatomes because you're almost a physical therapist. Could you tell me a little bit about it?
Yes. Well, dermatomes are regions of the skin that are I don't know if it's well said innerved
Okay,
for with an specific um the word is called raíz nerviosa.
okay, great. So what structures do you match each nerve root? ¿A qué estructuras superficiales asocias con determinados dermatomas?
Could you please repeat the question?
Yeah, sure. Ah, cuando estamos analizando dermatoma por dermatoma, hay estructuras superficiales a las cuales nosotros relacionamos con determinadas raíces nerviosas, ¿no es cierto? De eso se tratan los dermatomas. Entonces, ¿me podrías dar algunos ejemplos de estructuras superficiales asociadas a un determinado dermatoma?
Okay, maybe the clavicule
Okay, what dermatome does it
with
correspond?
C5.
Okay, great. Awesome. So actually, Mariana knows a lot about it because she's a physical therapist. So she's the one we could ask for. So a dermatomal pattern vary between individuals. However, it is mainly constant, right? That's why we match it to some specific structures, to specific nerve roots. That's what this is seen as pain or paresthesia, right? In peripheral nerve injury, it is a localized pain and there is paresthesia and weakness. These set areas that presents consistent with a peripheral nerve injury. So we actually find this type of mixed. Hello, I heard something. Okay, here we actually find this abnormalities such as pain, paresthesia, and weakness if there is a nerve injury. Those three main ones: pain, paresthesia, and weakness. Because it not only affects the sensorial part, it affects also the motor part. So the assessment of sensation. We have to assess with light finger touch, a light finger touch. And if there's a deficit that we find, then we have to perform a more detailed sensory exam. For example, while the patient keeps his or her eyes closed. That's how we actually determine if our patient is actually not feeling what we're doing. Also, we could assess sensation of all extremities bilaterally and to record abnormal findings of asymmetrical differences. To complete sensation testing instructed in the next lecture that we're going to have. So here we have the dermatome screen. So UE and LE actually means upper extremity and lower extremity. It would be almost the same as upper body and lower body, because it not only relates to the limbs, right? It is actually related to much more structures. For example, C4, long clavicle, C5, deltoid, C6, thumb, in Spanish would be pulgar, right? C7, middle finger, C8, little finger, T1, ulnar forearm. And lower body, L2, front mid thigh, L3, medial knee joint, L4, medial malleolus, which is actually the ankle, L5, dorsum of foot, right? S1, lateral heel and leg, and S2, popliteal fossa. So we also have to screen for muscle strength. Strength is actually in Spanish, fuerza, right? Fuerza muscular. So we have to screen muscle strength to get an idea of the patient's overall strength and to test the upper and lower extremities myotome muscles groups to get added diagnostic information. So we do this and well, as I've been in the hospital a lot of times seeing some patients, we always have to take into account this because there are some metabolic, even metabolic diseases that might decrease muscle strength, and we do not always pay attention to it. For example, in strong and painless, it would be normal. In strong and painful, it is a local lesion of the muscle or tendon. This is what Mariana must know a lot about. If it is actually weak and painful, it indicates a severe lesion around the joint. And if it is weak and painless, there is a neurological involvement or complete tendon rupture. This is actually really useful for you. So we have to practice both general and myotomal strength to screen for the upper and lower extremities. For example, here we have this doctor that is checking on on this patient's reflex. Can anybody what kind of reflex this is? Okay, Danitza Burgo, I didn't hear you for a while. What kind of reflex is this? And what is it? Tell me the nerve root this doctor is examining. ¿Qué reflejo es y qué raíz nerviosa está explorando? Danitza Burgoa. Hello, Danitza, are you here? Okay. What about, let's say, Danitza Zambrana?
Sorry, teacher, but I don't know see the image, the picture.
Okay. Do you see it now?
No, creo que mi internet está mal, no me cargan bien las diapos.
Okay, I'm sorry to hear that. Okay, let's go on to Marcela.
I'm not pretty sure, but I think it's reflejo branquial. No, the bíceps, perdón.
Yes.
Okay. And the nerve, it's musculocutáneo.
Actually, we're trying to examine a root, a nerve root, una raíz nerviosa, no un nervio en sí. Actually, what root are we examining here? You are right about the reflex. It is called actually biceps reflex, right? In Spanish, reflejo bicipital, right? So what root are we examining through this reflex?
It wouldn't be C5 and C6.
Okay, C5. Yeah. Okay, great. So C5 corresponds to biceps reflex. And generally, for example, this provides information on the integrity of the nervous system. And if we check on our patient's reflex, if it is diminished, it indicates a peripheral nervous system problem. On the other hand, if it is actually exaggerated, it indicates a central nervous system problem. So when we have this increased and diminished reflex, how do we call them? We actually call them hyporeflexia and hyperreflexia. Okay, so hyperreflexia is a diminished response of a reflex, and it indicates the loss of nerve conduction, lesion peripheral nerve or spinal nerve root, and it may be classified as lower motor neuron lesion. Okay, and a hyperreflexia, which is an exaggerated response, it indicates of upper motor neuron lesion. More on this consent taught in lecture that we're going to have tomorrow, because we are going to have our last class tomorrow, right? And when we're testing some reflexes, we have some basic instructions. We have to have our patient in a relaxed position, place the tendon on slight stretch, and tap tendon briskly. The tricks to enhance reflex response. Does anybody know what this maneuver is? Genre 6 maneuver. Anybody, guys? Okay, you're going to check on it tomorrow. It involves the hands and the thigh. Okay, you're going to check it for tomorrow. To clench teeth and to interlock legs. Those are actually some tricks. Okay, these tricks help us to relax some other groups of muscles. For example, in Genre 6 maneuver, I'm going to tell you now, to check on our patient's quadricipital reflex, we ask our patient to enroll his or her fingers and pull in different sides. You know, you might be asking, what does it have to do with our patient's thigh? It is like it's distracting our patient, okay? And it releases some reflex that we're actually checking on. For example, in this maneuver, we're like distracting our patient to get a more accurate way to check on our patient's thigh reflex. Okay, you're going to check those clenched teeth and interlock legs for tomorrow. Okay, and you're going to tell me what those are used for. Clenched teeth and interlock legs. So we have this peripheral reflexes. We have the bicep reflex, brachioradialis reflex, triceps reflex, patella tendon reflex, Achilles tendon reflex. So there's a lot of reflexes we could check on, right? And the one we talked about would be the biceps and the patella tendon reflex, which is related to Genre 6 maneuver. you're going to check on it, okay? We also have to check on the extremity girth. To assess circumferential muscle girth, girth would be like grosor, okay? And to assess joint girth, looking for swelling. So here, as I was telling you before, we have to compare both sides. In this case, if there's an increased girth of an extremity or a limb, comparing it to the healthy one, we could say that it is actually increased and we have to look for a cause. For example, some types of edema, unilateral edema, right? Because if there's a bilateral edema, that could be close to each other. And we have to screen active range of motion, that is AROM, that is what actually was telling you about. The first, AROM, which is active range of motion, is movement which a patient performs without assist. And Mariana here could tell us a lot about it. If AROM is full and pain-free, that pain-free means without pain, okay? There may be no reason to assess PROM. What does PROM mean? Passive range of motion. So how might you quickly screen AROM for example, shoulder, hip, and knee? Is there any disease you might be checking on AROM on a patient's shoulder? Any kind of disease you might check on your patient's AROM shoulder? Okay, Mariana, you're up now. You're next. ¿En qué tipo de patología tendrías que analizar la amplitud de movimiento activa en un paciente que tenga algún déficit en el hombro?
Artrosis.
Okay, great. Okay, who's next? Paola, are you here now?
Yes.
Okay, what about hip? Hip means cadera, right? So what about the hip? And no, do not repeat what Mariana just said, because it would be correct too. So any other disease?
Osteoarthritis.
Sorry?
Osteoarthritis.
Okay, that would be the same as Mariana said. Artrosis y osteoartritis son lo mismo, okay? And there's a difference between arthritis, rheumatoid arthritis, and arthrosis, which is actually the same as bone arthritis or osteoarthritis, okay? So any other disease?
I don't know, desgarro del labrum, de la cadera.
Okay, okay. Okay, the knee, well, we're going to leave it for another day. Mariana, could you tell me if you know Quiste de Baker? Do you know what it is? Baker's cyst?
I really don't know.
Okay, anybody? Baker's cyst, Quiste de Baker?
Es, es un quiste que está, creo, en la parte de atrás de la rodilla, en la parte posterior.
Okay, please say it in English.
Kyste is the same thing, right?
Yes, cyst is kyste, cyst, C-Y-S-T.
Okay. Is a cyst in the posterior part of the knee and in the I don't know how to say popliteo.
Popliteal, okay, fossa, right?
In that part.
And what is it all about? I mean, what kind of disease could you think of when you find a Baker's cyst?
Oh, I don't remember that.
Okay, it is actually osteoarthritis, or in Spanish, arthrosis. Okay, it could even show up in rheumatoid arthritis. However, it is much more common in osteoarthrosis, osteoarthritis, which is arthrosis. Okay, okay, great, thank you. You got an extra point, by the way. So, when we're checking on our own, we have to simply ask our patient to move their injured joint through its full available ROM. You know what a ROM and ROM are all about, right? And it shows the willingness and general ability to move and the patient's reaction to joint movement, the amount, nature of restriction and movement impairments. And to assess PROM, what is PROM? It is actually passive, right? So the examiner is the one who moves the joint, right? Yeah, Mariana just knows all about it, I think. And we have to look for the presence of pain, where in ROM, e.g., which is example gradia, right? For example, painful arc in the shoulder and the presence of muscles guarding, such as an spasm, and the presence of tone, for example, in spasticity, and to assess the end field, which could be normal or abnormal. Prom end field, what is it all about? It is to determine by applying overpressure to a joint at its limit to available motion. End feel is what the examiner feels. So, Mariana, could you tell us a little bit about it?
Yes. When we do a passive movement in a patient, well, every joint has a determined movement that has a normal range of motion. So we do all those movements, and in some cases, there is something in this that limits the movement, and that's how you explain, like, the examiner feels when the patient cannot move anymore. And
Yes.
there are different types of feelings, maybe like a sponge, or even sounds, or the patient reactions. And
Yes, it even clicks, right? You feel like something's clicking and stops moving. Okay, thank you, Mariana. Let's go on. And depending on the joint, we have three descriptions of normal and feel. There will be actually between quotes, right? And feel. So the bone to bone, it is actually hard and it unyielding joint. Structure compression that stops further movement, just like Mariana just told us. Tissue approximation, yielding soft tissue compression that stops further movement. And tissue stretch, firm springy, it is actually a slight give. Tissue stretch that stops further movement. That is actually what I think Mariana was telling us about. So there's a normal ROM. It is actually reduced, or the end field of abnormal quality. For example, in muscle spasm, it is invoked by the movement, sudden painful arrest of movement, and early protective after injury or late irritability or instability. The capsular, it is actually thicker tissue stretched at abnormal place in rump and frozen shoulder. The bone-to-bone is osteophyte formation. Can anybody tell me what an osteophyte is? Bernardo, maybe.
That means osteophyto.
Yes.
It's a cell.
What is it? You're right. It is actually osteophyta. Uh, could you explain a little what this is all about?
It's the main cell of the bone.
No. Osteophyta you can find in osteoarthritis, actually arthrosis. Okay, so when the result of it could be, yes. It is an excess of bony tissue, right? That grows around any joint. For example, in knee osteoarthritis, we could find osteophyte formation if there is osteoarthritis involved. Okay, the feeling of empty, it is that movement cannot be performed due to pain, but no real restriction is identified by the examiner. And springly block, it is actually like the tissue stretch, but unexpected place. There are actually some special tests for this. For example, in orthopedic, in neurologic, and specific to joint pathology and patient presentation. These tests are actually interpreted clinically and they are positive. It could be either positive or negative. For example, a straight leg raise is positive for sciatica. That is how you call it, sciatica. And when the test reproduces pain that radiates, we already talked about radiation, right? Down the leg is consistent with the patient. Original complaint or pain. Can anybody tell me the name of this maneuver in Spanish?
Maniobra.
Yes, what kind of maneuver is this? The one that we just described for sciatica involvement.
I think it's Lacer.
Yes, la segue and another would be la guerre, right? So great, awesome. Okay, so I think that would be it for today, guys. We're actually almost done with our classes. Let's have the daily poll, please. And let me know when you're done. And tomorrow we're going to have our last class, actually.
I'm done.
Okay, thank you. I think you're all, there's one person, okay. You're all done. Okay, thank you for your time and I'll see you tomorrow, okay? Have a good night's sleep.